So with that, I think we'd like to get started by addressing an update on COVID-19 issues, and then I'll ask a couple of questions, and then we'll move on to each individual doctor. So maybe we just want to open it up. I think my biggest questions are around what's happening in terms of what are you seeing in the clinic with COVID-19. Do you want to give us broad updates? And then maybe I'll ask some follow-up questions.
There's obviously some regional differences in the country about how many people are coming in with COVID and how serious it's been. In the Wisconsin area, we've had a relatively low case number. But one thing that did come up again when we were chatting, and I've had a personal experience with this with a few patients, we are getting a little bit concerned about people who may, for example, have myeloma, have some symptoms and are very scared to come to the hospital. We really hope that as people are starting to see some decline, that is not going to happen. But I know of a couple of cases where that really did have a negative impact.
Yeah, I think the number of patients that we're seeing, 2 months ago and now has come down quite a bit, especially last month in March, March and April, actually, the number of patients that we're seeing came down quite a bit, but slowly I think it's picking up. I can see based on our clinical experience, yes, last week and a week before, now the patients are, I think, a little bit more comfortable. But I still agree that, the patients, given the fact that, cancer patients and maybe myeloma patients are at a higher risk of getting COVID and maybe the outcomes, I think there is a fear out there. And we have been trying to, getting more data out. We still don't have a lot of data in that setting. So we're telling the patients that we are using all the precautions and making sure that they're getting the right treatment.
And I think one important thing to convey to patients is, as should be the case of all business in society, healthcare and cancer care facilities certainly have matched or exceeded what is necessary to be able to safely deliver care. So first and foremost, talk to your physician, talk to your treatment team, and if they tell you it's okay to come to the clinic and be seen, it is okay to come and be treatment, you really should trust that. I think, of course, the challenges out there is in society is real, but the hospitals have gone above and beyond to create measures to minimize the unnecessary interactions and be protective of the staff and be protective of the patients. And as we were discussing earlier, there's the risk of 1 or 2 extra trips to the clinic to receive the treatment that is much needed is going to be much smaller than the risk of neglecting or delaying treatment for the multiple myeloma. Just like Dr. DeCall, we saw a completely disappearance of new cancer diagnosed for a couple of weeks in March, just to see now, unfortunately, patients coming in with very advanced disease, patients who, in renal failure that, should have they seek care, 2 or 3 weeks before they wouldn't be that way.
Yeah, Dr. Callender and Dr. DeCall, are you seeing similar things in your clinic in terms of patients being more nervous and then having larger?
Yeah, absolutely. I really have felt strongly that there are people who need to be seen in person, and we've continued to see people all through this. Same way with transplants. Again, we've been fortunate to not have very large numbers of COVID-19 patients, so we can really, for the very small numbers we have, put them in one area in our hospital. So we've been transplanting right through this because for some people, they actually really need to have that done. Now, I don't think every institution's had that luxury that we've had just because of our geography, but I would agree with Luciano that our biggest concern is that we know people still were getting cancer. It's not like it stopped because of the virus. And I think we've all been very concerned about, among those deaths that are reported, how many of those people did have, say, an undiagnosed malignancy, perhaps myeloma, perhaps leukemia, something like that.
Yeah, so in our case, we didn't do transplant in the month of April. We deferred because we had, of course, everything was new, and as a program decision, we made kind of to defer the the transplant for myeloma. So those patients were on the list for transplant. They didn't get the transplants. We talked to the referring physician to increase the cycle of the induction. So go to 1 additional cycle or 2 additional cycle. But now we have started the process back on. So from this month onwards now, because we know more about this and we know the impact a little bit more, and we know how to do the precautions and all those stuff. So we have started the process. So a lot of our patients are on the line for transplant now. Having said that, there are a few patients still kind of concerned and nervous about coming down here, because Milwaukee, if you look at it, the number of cases in Wisconsin is the highest in Milwaukee County, where our hospital is. So people are kind of, coming far off from here. They are kind of concerned coming here. I mean, they're worried that if you're coming to the hotspot, maybe they are at risk of getting the infection. So that education that we're doing, that, what we're doing to prevent all those. So the number of cases getting transplant are increasing now.
Another question that I have for all of you is, has there been better definition, now that you have a little more experience with this COVID situation in your hospital, of who exactly is considered high risk for developing COVID severe symptoms? Because in my opinion, on a national scale or statewide scale, this conversation is we're not doing a good job at identifying, okay, here are the vulnerable people, let's separate them. It's not just elderly. It's people with these other comorbidity conditions that could or couldn't be, and then are myeloma patients at a greater risk, or just in those specific, with those specific comorbidities that's relative to the whole entire population?
So if you look at the evidence, I don't think there is much evidence out there, if, given the fact that a lot of data is coming out from China, because they are the earlier hit of those cases. So if you look at the patients with cancer, and particularly with hematological malignancies where myeloma is included, very small cohort of the studies are there. I mean, one from China, and then I can recall a couple of from China. In that, they definitely looked at the outcomes of these patients, and they found the outcomes are severe as compared to the patients who didn't have cancer or other hematological malignancies. So having said that, there are other risk factors in those patients that could have contributed as well. For example, as you said, age is one of the factors. Patient with other comorbidities like diabetes, hypertension, lung disease, so that could have contributed too. But cancer definitely is up there. Any cancer, and in myeloma per se, we don't have a lot of data. Based on our own experience, we have four of our patients who had the COVID. 7 of our patients who had a COVID, and it didn't look that good in our cities. But we have to look at the larger scale and to see if that myeloma really puts them at a high risk.
And the thing those are very good points, Dr. Rakal. And the other point to make is there's myeloma often overlap with some of the other conditions that we know are predispose somebody having bad complications. Being older, hypertension, diabetes, and so forth. It's certainly, and also is important to keep in mind that, not all patients with myeloma are the same in relation to their disease and the treatments they're in. One can, I guess, estimate that the risk of somebody who is is disease well controlled on maintenance with Revlimid is probably not as high as somebody who is, receiving triple, quadruple therapy, or somebody who has had multiple lines of therapy and now, is just received CAR T cell, for example. So the risk is probably not the same across the spectrum. And I think it's going to take a lot more data to figure that out. But I think the important message is, as far as we know, all those factors contribute to have a negative outcome. Once you acquire, they don't make you more propense to acquire the virus. And I think following national and regional guidelines and following the policies of the clinics that the patients are going to, still the likelihood of one acquire COVID-19 in most places is still quite small. So nothing that would justify patients, getting away from treatment.
Yeah, I think I totally agree. Based on our experience, those patients who had the COVID, None of them acquired through to coming to the clinic or through the hospital, so all of them had community acquired, the transmission.
That's a very important point. I mean, on the early days of this crisis, we slowed down our transplants as well. We never stopped completely. And it was really more as a fear of that our whole healthcare system was be so overwhelmed that we couldn't spare the workforce. We couldn't spend the workforce and the hospital capacity to take care of those patients. Fortunately, that never happened. All hospitals have taken measures to keep COVID patients on a separated unit with proper isolation measure, dedicated staff. So, the fact that you're coming and getting transplant on a hospital that has COVID patient by no means that you are at increased risk of being exposed. I think in most settings, I really haven't really heard of reports of cancer patients on cancer hospitals acquiring COVID in the clinics or in the in-hospital setting.
So I just want to make a couple of comments, Jenny. I think the study that you're doing is very important because I think the experience is going to vary from patient to patient around the country. And there was a publication that came out of Montefiore very recently looking at outcomes specifically in cancer patients who had COVID. And those with with blood cancers did do worse, just as a factor, perhaps not surprising. So I think there's a lot we have to learn. And I think, as Luciano alluded to, there is a lot of opinion out there, but boy, do we need data. We need data about prevalence of the virus. Where is it? Who's had it? How many people are going to get it? I think for the areas like our part of the world that have been less hit, I think the concern now is turning more towards a boomerang effect, come the fall, because very few of our populace look like they're antibody positive. In other words, they might have protection against COVID. So if there is a big outbreak, I think, we may have sort of gotten off easy, if you will, right now. But I think there's a concern that later in the fall, there's going to be a much different situation. And that ironically, places like New York City and Boston and Chicago and Detroit may actually be in a better situation. So I think, Jenny, it'd be very, very insightful for the audience to ask in the second half some of these same questions and see what Dr. Zonder and Dr. Shaw have seen.
I agree. I think it's varying across and we just don't know yet. So we had 2 individuals who had confirmed cases of COVID, and one had a very bad side effects and very serious complications and took several weeks. And the other was asymptomatic, and they both were taking the rapid antibody test kits. And the one with severe condition showed a very strong IgG line, but the other one, who was asymptomatic, showed nothing. So it begs the question, if a vaccine is developed for this, will myeloma patients or the broad community develop the IgG antibodies towards this? I have no idea. What's your opinion?
I think there are a few data. I mean, again, it's all small scale data, but people who are symptomatic, and depending on the severity of the illness, I think the antibody production also has been seen to be correlated with that. So people who are asymptomatic, they are not mounting very strong antibody response. That is in general population. The small kind of observation. So we don't know in myeloma, things are a little bit different because they already have this humoral deficiency and the impaired B cell responses. So that applies same to myeloma or no, but there are some data out there that to mount a good antibody response, you have to some sort of symptoms or some sort of a little bit severe illness.
Dr. Costa, do you have any insights about that?
I think, like for any other vaccine, it probably depends a lot where you are on the myeloma trajectory. Yes, ever treatment that is good at killing malignant plasma cells is excellent at killing the normal ones that eventually make the antibodies that give protection. So I think it's going to depend very much on what phase of therapy the patients are in. But the principle that I think is important to emphasize for any transmissible disease, the way vaccines work is, in part, of course, the individual protection, but also, what we now, the popularized term, herd immunity. And the principle, taking a different disease, what I usually tell the families that I see, around the flu season is you, the patient, take the flu shot. We don't know if you're gonna mount a response or not, but everybody in this room and everybody who go ahead and take the shot, because by protecting themselves, they're also protecting you. And I think if we're fortunate to soon have a vaccine for COVID-19, the same principle should apply.
I think, I think that's an excellent point, Luciana, because there's been some small studies now that show that myeloma patients in particular who do have evidence of mounting a response to the vaccinations they are getting, particularly after transplant, seem to do better. And so I think, while we're all focused on the virus, I think we don't want to let normal health concerns, we do want people vaccinated for pneumococcus and influenza, as you mentioned. And so, I know there's been sort of an interruption of a lot of that kind of sort of standard health maintenance for our patients, but it's really important that we continue that too.
Okay, we have a question, and we're going to have a a very extended Q&A section for later in the program. But this one is really relative to COVID, and it's from Joanne, and she's very immunocompromised due to the myeloma, and she's taking extreme caution. But she's wondering if she's just overreacting by not holding her grandchildren, for example, and she's been quarantining since October, following a pneumonia and sepsis. So she's been quarantining for 7 months. So is that too extreme? I think this is a broad question. Patients are wondering, to what extent do I go? Do you have any insights?
I'll give the honest answer that I give to my patients. Of course, at a society level, social distance is clearly very impactful and is helping contain these epidemics and to use a popular term, flatten the curve. And everybody is individually responsible to contribute to that. And I think we all are. And our patients are more than anybody, because they already, some of those practices are already very natural to them. They know, before there was COVID, there were other challenges the patients fear, flu and others. They were used to those practices. As time goes by and, weeks turns into months, I think it's very important that we balance that against our well-being and our, happiness. And so what I tell patients is, we don't want you to go to a rock and roll concert or be the first person in when the bar is open. But, if you have that core of people that are very important for your life, and they're well, they're healthy, they're taking precautions in terms of interact with the broader public, make that kind of micro society quarantine or self-isolated in small clusters of family or people who are meaningful to your life. That will definitely help lower the burden of coping with those measures for a very long period of time, and essentially keep you happy, keep your life meaningful. Because being by yourself at a time of so much uncertainty, so much fear, when you're already facing cancer, is not fair, and it's probably necessary. I think the increased risk of adding your grandchild and your daughter and your son-in-law to that little nucleus of people who are kind of isolating together, if you will, is probably neglectful and has probably much more benefit than risk.
Yeah, well, that's a great answer. And then Dr. Callender, you mentioned some of the early data that we're seeing on blood cancer patients as a whole being higher risk. Mm-hmm. And some of that data looked like it was leukemia or lymphoma patients, not necessarily myeloma patients. And many of those were on checkpoint inhibitors, mm-hmm. who seem to have the worst outcome, mm-hmm. which myeloma patients are not necessarily on. Is that something that everyone wants to address?
I think this is, again, we have a paucity of really good data here about how certain drugs may impact. And I'm sure all of the panelists have heard from colleagues, that, for example, a colleague of mine said, boy, we've seen that people starting initial therapy on, say, bortezomib, lenalidomide, and dex are doing terrible in our part of the country. I've not personally seen that where we are. And again, I've heard other colleagues say that, boy, our patients who've been on lenalidomide maintenance don't seem to be doing well. I just think we have got to get some sort of organized data bank going so that we could understand this a little better. You know, is that everybody getting these drugs? Does it depend on the region? Is it your age? Is it, as Dr. Costa said, other cofactors like diabetes or hypertension? I think we're all sort of really operating in the dark.
Yeah, so I can add on a few lines on that. So I agree. I think if you just look at the data, I can recall there's two studies that came out just recently. One from French group, they looked at purely hematological cancer patients, 25 patients, and out of that 10 patients had multiple myeloma. And if you look at them, they were in various stages of treatment. And their outcomes, you know, if you look at it, not that the best outcome that we want to look at. And then the other study came from China with a group of patients. Out of that, only 3 patients have multiple myeloma. They didn't specifically look at the outcome, describe the outcome of that patient. So at this point of time, we don't know what medication put them at a risk of, having a bad outcome with the COVID. Based on our own experience, out of those 7 patients, I can tell you they were on different stages of treatment. Some were on induction treatment, some were on maintenance treatment, some were relapse refractory treatment, and the outcomes were independent of that. So I think what we need is a, kind of a large scale data, and that probably would help us find out what put them at a high risk.